Hi, good morning, everyone. My name is Carrie Newbold. I'm the Director of Clinical Research and Development at Kensana Health. And as part of that role, I support the research arm for ECS Clinic. So today I wanted to talk specifically around real world evidence. I think there's a real uh, benefit and need for this in cannabinoid research within Australia. So this is my current role. So I've been within cannabinoid research for probably 3 years now almost. But before that, it was all cochlear implants. My background in research was really from bench to bedside for bionic years, maybe about 20 years now. Uh, but it was actually my part-time job while at uni that got me aware of real world evidence in the first instance. So I happened to work as a body piercer, and this clinic that I worked at was just body piercing. So it was a bit special in the sense that all that it was body piercing, and that the nurse who ran it was actually interested in real data and real results. And so she encouraged everyone to come back for a checkup 6 to 8 weeks after their appointment. And it was pretty obvious to me after working there for however many years that we had thousands of wonderful data points on how piercings heal. And this just sat in our files. And it's this kind of data that certainly we knew internally for ourselves and helped us decide how to best teach someone or how to best pierce someone. But really, we could have taken the data out of there, done research on it, and then moved the field forward as well. And this is where we potentially can use our clinic data in cannabinoid work to do the same. So today I want to really cover the why, the what, and the how behind real world evidence. So let's start with the why. The why bother. So there's already plenty of work out there, right? So, a simple Google Scholar search found that in the first, in the decade of the 1960s, we've got about 40 papers on cannabinoids. Down to the previous decade for us, it's been about 50,000 papers on cannabinoids that has cannabinoids within it. And this is just going to grow and grow and grow. It seems like a big number, but this is a really complex field. I would see this as just the beginning. So not only do we have a plant that has 500 plus molecules, compounds inside, we've also got a system, or it's working on a system that is really far-reaching. It hits all of our bodily systems, and so because of that, it's also impacting a whole lot of indications. So yes, there's a lot of research that's been done already, but I think it's iceberg stuff. It's very much tip of the iceberg. There's another particularly important reason for research, but also particularly important reason for real world evidence and real world research is this idea of a research clinical translational gap. So on average, we're talking about 17 years. So 17 years from when it's known, something is known in research, to it's being used in clinical practice. For me, as a patient and a clinician and a researcher, I think that's a really long time. So real world evidence can really help to bridge that gap. So we can do that by, yes, we have our pile of research that's already occurred, and we can use that to develop the education that we use for clinicians and health professionals and even patients. But we continue on and actually working in the data and collect the data that we're getting from patients and the results and outcomes we're getting, marry that in with the research that's there, and evolve our research and evolve our education, which hopefully evolves what the patients are being recommended or counseled for. So this cycle continues onwards, and hopefully it brings that gap between research and clinical practice to be a much smaller option. There's also regulatory acceptance. So the regulatory bodies in Europe, for example, with EMA and FDA in USA and even TGA in Australia, they're becoming more and more interested in real world evidence as something to use for new drug registrations. So Europe's put out guidance. The FDA is already allowing for real world evidence to be added to new drug applications. And the TGA, while it's a smaller body, it's definitely taking it seriously and looking at this as an option. So the standard issue historical use for real world evidence in regulatory approvals was really around post-market evaluation. Something has been approved and then it goes into the market, and it's that post-market evaluation, that real-world evidence is used to show that, yes, it actually does happen. It's what they said it was going to be approved for is happening out. But that's not the only way. And now more and more, we're seeing real-world evidence to be used for in rare diseases, orphan diseases, life-threatening diseases. So stuff that was real, it's very important that we're not waiting for lots of big, expensive trials to occur. We need to be taking notice of what's happening right now and in the field. The other opportunity for this is revising indications. So when it's, if something's been approved for a particular kind of epilepsy, but then it gets used for this kind of epilepsy as well, then that real world evidence can be used to further the indication pile for that application, for that drug. Drug combination, so we're not ever using drugs singularly, or sometimes you are, but in most situations it's one drug and then a patient's on another 5 or 10 as well. So how these drugs interact with each other, real world evidence is the way to be gathering this kind of level of data. And then, of course, the other one is guiding clinical trial design. So this is not just in terms of inclusion, exclusion criteria, but also in terms of the target population and how these different cohorts of people respond to different medications. So a bit of the what. So we've got preclinical stuff, so the animal work. In veterinary land, that's not preclinical, that is where it's aiming for. So what's happening in both the cell, so in vitro, but also in animals. Then we have our clinical side of things. So this is observational. Observational is real world evidence usually. Like, it depends how you cut the mustard in terms of the trial design, but certainly observational studies is that real world evidence bucket that I'm kind of talking about. And then there's experimental, or sometimes called interventional. And that's the clinical trials, the randomized RCTs. This is the kind of stuff that the regulatory bodies used to only ever look at. And now we're looking at a broader option from a clinical perspective. What's worth considering here too is that's not the end of the line either. We've got our reviews as well, where we effectively look at all the data that's been calculated, it's been used, and smash it all together and work out what's real and not real kind of thing. And this is where the reviews from the systematic ones, but also the meta-analysis, where they actually do the maths again on multiple randomized controlled trials. This is important pile two. So the NHMRC, so an Australian government body that sort of handles medical research, the Medical Research Council, they have what's termed an evidence hierarchy. And at the top of that are those systematic reviews. So this is the systematic reviews of level 2, and we'll tell you the level 2 is, of course, the randomized controlled trials. So this is the hundreds of people that are all have the same indication, and then they do the same treatment for them, randomized to this, that, and the other. I'll talk about that in a moment. But what's now becoming more and more valuable from a regulatory point of view are these level 3 and level 4 options, so the real world evidence pile, so that we can be coming from. So this is really where, you have your single patient that has, not a single patient, maybe 10 patients or 100 patients in a single field, single area, where we're looking at the results, their outcomes beforehand, treating them in a particular way, and then looking at the results afterwards. I've said real world blah, blah, blah a few times. Let me spell out what I mean in this instance. So there's a few ways that you can kind of describe it at this point. Real world data. So this is the singular data point. So my result is a single real world data point. Then if there's 10 of me and we're looking at all together, then together our results might be real world evidence to say this is working or not working. And then a real world study is the wrapper that would go around the 10 of us and our work. So it says, I think somewhere here, it's not, maybe I've pulled it off, but it's these kind of nomenclature stuff isn't particularly finalized at the moment. It's sort of, these definitions are good, but when it gets down to the, this country level as to whether they call a study an observational study, a non-interventional, it shifts between the locations. But generally what we're talking about for any kind of observational non-interventional study, what we really want to do is see a separation between what's been clinically prescribed or the current practice that happens for that patient and the research study. So there's a separation there. It's not the researcher saying, I want this patient to get that and that patient to get this. It's the clinicians, and the researchers are just looking at the results. So that level of separation is what we're talking about for real world evidence and these non-interventional studies. So depending on the study type, these ones may not need ethics committee oversight, but it's always nice when there is. So an ethics committee can, like a group of people who have either like research experience or that clinical experience, or they're lay people who are interested in the ethics for their community. And so most hospitals, universities, medical colleges, and even some private ethics committees exist. And companies and research organizations go to them, present an application. So for example, the application we put in for our REST trial is with the Australian New Zealand College of Cannabinoid practitioners. So this is an example of a medical college in Australia that it has an ethics committee that provides oversight for particular trials and other things. So the trials may exist, just within, you find out about a trial because you've gone to the doctor and the doctor said, oh, we're participating in this kind of trial. Would you like to enroll? Or you can go straight to the trial registries to see if there's something listed that you might like to participate in. This is both from a patient perspective and also from the clinician's perspective. The clinician might also be wanting to know that this kind of trial is available for their patients. So ANZ CTR is one place to look. There are a few around the place, but this is certainly the one that is probably most commonly used in Australia. Okay, so more details in the how for research. So generally what we're talking about is research is just amplifying standard clinical practice, or a bigger version of it. So in normal clinical practice, you go see your doctor, your physio, massage therapist even, and they're assessing what's going down for you right now. And that might be blood tests, questionnaires, a conversation about your goals and outcomes, what you're trying to achieve. Then there'll be some form of treatment. So for us at the moment, we're talking about cannabinoid medications. And then afterwards, at some point, we've got a reassessment. How is that? Maybe you're remeasuring your bloods, maybe you're redoing your questionnaires, maybe you're looking and asking questions. How did you hit back to those goals or not? And so this assess, treat, reassess is really the basis of clinical practice, but it's also the basis of most experimental research. And for our real world evidence, it's this kind of conversation, this pre and post treatment, that we're wanting to compare and observe. So one of the things I kind of wanted to touch on, a few other things that that we want to pull out of wherever we can. So bias is one form of error that might happen in research. And so there are lots of ways, and we're only finding this is very much an incomplete list, but there's lots of ways we can be biased in both all the planning of a trial, in the implementation of a trial, and in the analysis of a trial. And wherever possible, if we can know about them, then we can learn to or work out ways to reduce that bias. So one of the ways that we can use to reduce errors and bias generally is, can it be reproduced? So can a bit of research that I've done, can I tell you how I've done it? And then you can go off and repeat that research and come up with the same answer. If it's same, you can go, great, it's reproducible. This potentially is real. This is a real situation. This is, in some ways, this is what's happening with the using real world evidence in post-marketing analysis. So you've got your clinical trial that you've done on this particular cohort of people. We've gotten approval and we've gotten it out in the real world. And does it behave as you expected it to behave? Is it reproducible? Are the results the same? If yes, great, it's reproducible. Let's go. And if not, then we've got to look back. Well, what's happening here? Did we get our cohort incorrect? Have we done our methods incorrect? Are we applying it incorrect? Where's the gap? Then there's other ways we can play to reduce bias, particularly, and also some of the, bias, I think, for this one. So this is the idea of using a control group. So occasionally I can be my own control group. So I had a particular treatment and I saw what happened pre and post that. And then I've had this other treatment and I've seen what's happened pre and post that. And my results are my own control. Or you can have control, so I can get a particular treatment. I can have my cannabinoid treatment for pain or whatever else I'm being treated for. And then you can find someone who's just like me on a piece of paper, and you can use that person as a control for me. So a particular kind of control is what's known as a placebo control. So placebo is something in the positive, so I feel better, and so I get better despite this. And nocebo is the opposite. So this is something that can make you feel worse, kind of thing. So they're effectively flips of the same coin. But this idea of a control, a placebo control, this is often only or usually only part of the experimental, the interventional. So it's not ethical for us to have a placebo or nocebo in a real world evidence trial, because you're not, again, remember that separation between clinical practice and research. The doctor's not coming up going, actually, we're just going to pretend to give you real something, like a sugar pill, but just pretend it's real kind of thing. That this is not what's happening in real clinical practice. And so then for our real world evidence, this is also not what we're seeing. But blinding is something we potentially could have a little of. So normally blinding is when the patient doesn't know what they're receiving, whether it's the control or the real treatment, or maybe the doctor doesn't know whether they're delivering the control or the real treatment. These are two kinds of blinding, single blind, double blind. But there's a third kind of blinding where the assessor can be blind. And this is something that we potentially, depending on the design of the study, potentially we can be having in real world studies, is this idea of that third blinding. The assessor is blinded. The assessor doesn't know what the treatment is. They're just looking at the results. And then later they'll find out what treatment any one of those patients might have had. Randomization is, alongside the placebo, is something that occurs within real world, sorry, not real world, within randomized controlled trials. So it's not the clinician who chooses whether you get the control or the treatment. The spreadsheet, the number out of the hat, is the one that tells you for that. And so that's something that we can't achieve in real world evidence, but we certainly can be achieving in the randomized controlled trials. An important component for this, hi, my dog's coming to say hello, is whether the impact of any and all of these, I guess, techniques, research techniques, and what it tells us. So often, real world evidence is just looking at what happened. And so all it can tell us is there a relationship? Is there a correlation between the results this group of people are having and their treatment? Is there a correlation there? What the randomized controlled trials can do, or the interventional work, but also the preclinical stuff, is that they can start talking about causation. Is this, when we've seen a correlation between here and here, is that because we've applied this? And so that's what together the different kinds of research can give us. So it's not one over another, it's together, sticky tape together, what can we achieve from these different kinds of research? The last little point that I think is probably one of the most important points is this idea of real world evidence is real. So it's messy, there's missing data, or you're often modifying what would otherwise be in a validated questionnaire, but it's, that questionnaire is 15, 20 minutes long, and you really want to get the information quicker, and so you're modifying that questionnaire just to not lose your patient's interest. These patients, they're patients, the priority is giving them their treatment, and the real world evidence, the research happens on top of that. That's priority number 2. So often you're dealing with data that's really, it's real, it's incomplete. And from a researcher's perspective, it's really annoying. But from the reality, we always have to give ourselves a reality check there, is yes, it'd be much nicer if it was complete, but actually we want to see what it looks like in the real world there. So I am hoping that this helps to kind of, I guess, give more understanding about what's going on, and really that expectation of change. Like, we are really only at the beginning of any of this research, as was often the case for any research, but particularly for cannabinoids. And hopefully, maybe I've inspired you as a patient to be part of that change, to participate in a trial that your clinic is running, or if you're a clinician, maybe you want to actually start running a trial, because it definitely can be adding to the depth of research and the depth of understanding that we have in this field just generally. Thank you.